Okay. So those are my disclosures. Okay, so what are the advantages of arthroplasty? I think you've heard that repeatedly today. There is no question. It's a good procedure, and sometimes a lot better than a fusion. So you prevent adjacent segment disease through preservation of motion. You have a faster recovery. You're not sitting waiting for a fusion to happen. You're not bracing a patient. And you should have lower incidence of subsidence because it moves, and you maintain disc height and get indirect decompression. So we heard about anterior arthroplasty all this morning, but we never talked about the disadvantages. And so there is always a risk of vascular injury, risk of retrograde ejaculation, post-op ileus, revision complications, and you heard Dr. Ziegler this morning. Compromised stability if you do too much release, if you do too much ALR release and annual release. You could have migration, extrusion. And sometimes, because of the vasculature and the approach, you're limited as to your mediolateral dimensions. The vessels just won't let you span the disc space mediolaterally. And in the literature, it shows a facet degeneration rate of 20 to 36%. And in that case, it's going to be a limited protection towards the adjacent segment, So why lateral arthroplasty? Why all this concept? So everybody knows lateral approaches, the X-lift, the original X-lift approach, and the 15 modifications after that. So people have adopted lateral techniques. People are familiar with that technique. And the lateral approach preserves both ALL and PLL. So technically, if you preserve the PLL and the ALL, you're going to maintain motion within physiologic range. It's an easier revision because you're not dealing with the vessels. You can go back through the same side. If you do a retroperitoneal approach, you can go back through the same side without much adhesions or hopefully no vascular injuries. And it spans both apophyses because you go from medial to lateral, and your vascular risks are minimal. Also, there is a potential for short hospital stay and even outpatient surgery. So what does the ALL do? Well, undoubtedly, it's the strongest ligament in the spine. Failure load is 450 newtons compared to, let's say, capsular ligament or ligamentum flavum, which are in the 200s. So the ALL restrains hyperextension. There are studies that show that if you resect the ALL, you just increase your facet load by 700%. And that's why patients who have to qualify for IDE studies. They cannot have grade 3 or 4 facet degeneration. And then because of hyperextension and facet load, you're going to have increased risk of subsequent facet disease. So Punjabi's study, they showed that if you remove ALL and PLL, you increase horizontal translation by 33%. So one of the studies that done by Pimenta's group is they took 6 frozen cadaveric specimens between L2 to S1, and they studied motion segment kinematics using optoelectronic system. So they studied intact spines with L4-5 lateral TDR, and spines with L4-5 lateral TDR plus ALR release. And they looked at a range of motion as well as a neutral zone. And this is the lab study that they did. So when you look at flexion extension, if you put a lateral TDR without ALR resection, it's slightly more than 50% of intact. So not a lot of more motion. It's basically within physiologic motion. You resect the ALL, now you went up to 120, 130%. If you look at lateral bending, same thing. Lateral bending is roughly within physiologic motion. Resect the ALL, you're up to 140%. And then axial rotation, that goes up to 200% when you resect the ALL. So undoubtedly, when you take out that ALL, you're going to have more motion and potentially more instability. As for the neutral zone, which is that zone within physiologic motion that's accompanied by maximum laxity, meaning that if you have a higher neutral zone, then you have more potential for instability. So when they looked at that when you resect the ALL, neutral zone went up to 300% as compared to physiologic. When they resected the ALL on lateral bending, went up to 400%, and axial rotation way up to 500%. So neutral zone is a lot larger now. The other case we want to make is that when you come in lateral, you're not constrained by the mediolateral dimensions of the vertebra because you're going to be able to span the apophysis. And you look at Grant's study where they showed actually the bone is strongest I'm not sure how to do this. Which one does?
Yeah.
Is it on the side?
Top.
Oh, this one?
Just gotta hold it.
I don't know. I don't see it.
Sorry, it's not connected here.
Oh, it has to be connected. Okay. So they showed that the strongest bone is on the sides, the apophyseal end plates, and posterolaterally. Anteriorly, the bone is not that strong. So the prosthesis is designed to span those apophyses from side to side. The XLTDR, which is the lateral disc prosthesis that we use and has been used in the IDE study, basically it's a ball and socket. It's metal on metal, and you heard that from Dr. Ziegler earlier today about the concepts behind ball and socket as well as metal on metal. And it has fixation spikes, no keels. So the spikes serve as markers. So when you look on the lateral view, the center of rotation is posterior, so the spike on the lower end plate represents your center of rotation, and the middle spike on the upper end plate is basically the midline. Great, perfect. Thank you. So this spike on the upper end plate, basically that would be like mid-vertebral level between posterior and anterior, and this spike represents the center of rotation, so you want to put that behind the midline. So you want to put it along the instantaneous axis of rotation. So, and it comes at different ranges of lengths and heights, etc. And it's cobalt chrome, again, metal on metal. There is a long history of arthroplasty, hips and knees and all that. But that became a problem with the FDA because it's metal on metal because of the history of hips. And 2 of the IDE sites in the US did collect serum chromium levels. To my knowledge, none of them showed increased particles. So one of the first reports was by Marchi et al. This was a single-arm, non-controlled study. They looked at the first 36 patients from December 05 to 06. Now, again, it's all comers. So you have 15-1 level, you have 3-2 level, you have 18 hybrids. So it's not a clean RCT level 1 study, obviously. So this is like a single cohort, 1 surgeon experience. So they found 14% psoas weakness, 8% thigh weakness that resolved within 2 weeks. And this is very, very similar to if you read the XLIF data report, literature. I mean, that's what it shows. And they had significant VAS improvement as well as ODI improvement on those patients. There were no intra-op complications, and average range of motion was about 8%. They found contralateral heterotropic ossification of about 14%, but that study and subsequent studies proved that lateral ossification you see is really not correlated with a poor outcome. They had 2 cases go to autofusion, and 4 patients had post-op facet pain. All were hybrids. I don't know why. 2 were converted to lateral interbody fusion. Again, it was done through the same approach. This sounds anecdotal. It's not an RCT, but at least it's somebody's experience. And these are the clinical results up to 36 months, the VAS and the ODI. So their conclusion was that if you preserve the ALL, you have a better biomechanical construct, and it prevents anterior displacement and facet loading. You have better ligamentotachsis and sagittal balance, and it gives you a more natural neutral zone because then neutral zone is not increased and a more constrained motion. And they felt that this could be a viable MIS alternative to lumbar TDR. And then Dr. Pimenta reported on 60 patients up to 10-year follow-up. So their comment was all other lumbar TDRs, you need to sacrifice the ALL. And they felt that the XLTDR, you maintain the ALL for the reasons I just mentioned. You have controlled motion. And up to that date, the longest follow-up published was 3 years. So they felt that they should publish that. So out of the 60 cases, 49 cases made it to beyond 5 years. So they had, so this series is minimum 60 months, maximum 120-month follow-up. but 49 of the 60 cases made it. So they concluded that it provided fast and sustained clinical benefit up to longest follow-up. And the longest follow-up, well, the average was 93 months. They found 21% spontaneous fusion, because of heterotropic ossification. And they used the heterotropic ossification classification by McAfee. So this is what I was talking about. If you get a little lateral, like a grade 1 or grade 2, it's not a big deal. But when you have that, I mean, that's basically an autofusion. So in that series, with the average 93-month follow-up, they had a 21% spontaneous fusion rate. And this is a distribution of HO. So everybody had some evidence of HO, but the more severe ones were about here. They required 5 revisions, which is 10%, and they all revised them through the same lateral approach, basically took the disc out and replaced it with a cage and bone graft. And they were done mostly for persistent pain, and one was for allergy, and 2 because of inadequate sizing. And so these are really, I've revised a couple. It's really not that hard. You do the same approach. You get the osteotome. You turn it kind of like a cervical. You go with the osteotome, boom, it just comes off. So it's not keeled. And Dr. Pimenta has revised charités like that. Again, charité is not keeled. I imagine keeled would be a lot harder to revise if you want to revise that. So their conclusion, 60 patients, 66 levels, 82% had 5-year follow-up, and average was 93 months. Surgical time, including learning curve, was about 2 hours. This is a bit higher than the US IDE study, and 5 required fusion, and 2 patients developed ASD. And 21% had grade 4, HO, VAS, back and leg both improved. And they concluded that it results in rapid mobilization, low risk of ASD, satisfactory pain relief, and improved function. And they felt, again, it's a viable option for DDD. So the FDA used that data to allow us to do an IDE study in the US. This was 17 sites. And inclusion criteria, 18 to 70. I think we mentioned last night, what was it, 18? It was to 60. So they did 18 to 70. And for decreased disc height, it was anything more than 2 millimeters. So they did not put a ceiling on like 50% or less. They did not do that. And so, I mean, criteria was pretty strict. There was a lot of exclusion criteria. Previous laminectomy was not an exclusion. Morbid obesity, of course, but if you've had a previous maculoskectomy, it's okay. So little technical pearl, when you dock with your retractor and you need to do that, you always got to think about that IAR, and you got to be more posterior than usual. And when you implant, this would be the center of rotation of the prosthesis. And then this is the marker for the inferior end plate of the cephalad vertebra, which is about halfway, and then that's the center of rotation. So you gotta, just like an ADR, just like an anterior, you gotta pay attention, to that AP, make sure your rotation is perfect, make sure you span it, make sure your axis of rotation is posterior enough. And then basically you insert the prosthesis, you assemble them, you assemble the 2 pieces on a holder, and then you introduce them at the same time. So out of that IDE study, so the FDA never approved the device. It's approved in Europe, it's CE marked. It did not get approved in the US because metal on metal, and 2, it's not an RCT. So they said you did not have controls. So they tried to use the charité data. They said, no, you got to do your own controls. So it's a shame. So Dr. Smith from Vegas and myself, we pooled our cases. We were the top 2 enrollers in the study. So we had 64 patients, 42% female, average age 45, your typical TDR population. Smokers, 20%. I know that question came up this morning. 72% were actively employed, and 95% described themselves as moderate to heavy activity. Back and leg pain, all of them had leg pain component in addition to back pain, and deficits were present in 58% of the cases. So mostly they were at 4-5 levels. which is very important because there has always been criticism with transpsoas approach, getting neuropraxias of the femoral nerve, especially when you do L4-5. So they were mostly L4-5s. And blood loss was most of the time less than 50 cc's. We had a couple above 200. And interestingly, 57 out of the 64 were done at a standalone surgery center. This is not a surgery center attached to a hospital. This is standalone surgery center. 2 were done inpatient. These were actually early learning cases. And we had 5 done at the hospital outpatient. So I thought, I mean, this really makes it attractive as an outpatient procedure. Most of patients had pain for more than 2 years. 9 patients had previous LAMIs. 37 out of 64 had pre-op deficits. Sorry. And that's the post-op. So post-op complications, hip flexion weakness in 10 out of the 64 cases, quadriceps 7 out of the 64, most recovered in 3 months, and then another 2 recovered in 6 months. Mild hyposthesia recovered, dense hyposthesia resolved in 12 and 24 months. I mean, that's a long time. It's inconvenient. Patients hate it, but these are the facts. So the results showed 87% blood loss less than 50 cc's, 94% outpatient setting, 97% less than 24-hour hospital stay. We had no patients go to the ER, hospital admissions, no intra-op complications, no intra-op conversion to fusion. If you're doing this procedure, you back the ALL, you got to fuse. I mean, the design of this prosthesis, you cannot have an incompetent ALL. I mean, there's no keel, there's no stability that way. So you got to be very careful. And within the 3 years, we had no explantations, but I can tell you that I removed 2 subsequently. After the 3 years, I removed 2 because of pain. Converted to a fusion. Sometimes you don't know why, but it just happens. So these are the vast 2 years and 3 years, significant improvement by 3 years post-op. So, and those, we use 15 points for ODI and 20 for VAS. So vast majority of patients, did pretty good. And these are the clinical outcomes: ODI, VAS, back, leg, mental and physical component, SF36. So case examples, this was a patient, 62-year-old lady, ODI of 48, back pain of 8, right leg pain of 9.2. I mean, severe degenerative disc disease, foraminal stenosis. She was in the IDE study, in the US IDE study. This is her 1-year follow-up AP and lateral flexion extension views and AP view. ODI went down to 4, leg pain down to 2.8. I mean, tremendous improvement. I still see this lady several years now. She's still doing fine with respect to that. This was a wrestling coach, 42-year-old, tough, strong guy, 2 previous laminectomies at 4-5, more back than leg pain. This is his MRI. You can see the laminotomy on the left side. So he was having leg pain too. So he just did not want a fusion. We took him outside the US and we did a XLTDR at 4-5. This is his 4 years, Xray, very minimal HO, if any, good motion, flexion extension, very little HO here. And this is his 6th year. I saw him like in December. This was his 6-year follow-up, still holding, no adjacent segment disease. Again, it's anecdotal, but it's nice to see. This case was in the IDE study. This is very similar to a case somebody showed today showing this large central disc herniation. I think, Mike, you showed a case like that. So L3-4 degenerative disc disease, 3-year history of back pain, more back pain than leg pain. I mean, this is a tough situation. 37-year-old, active guy. I mean, you don't want to do a microdiscectomy on that. I really like to avoid doing a fusion on the guy. So that's what we did. And through the lateral approach, we actually got some angled curette, some angled kerosene, and I pulled out that piece from anterior. I mean, just like, I think, Jack showed the case? Or you showed that case, where you pulled the disc in the front. That's right. So you can do it from the lateral position too. You get some angled instruments and you can pull that piece. And he's like 7 years now, or 8 years, and he's still doing fine. And this is a dilemma here. 45-year-old lady, axial back pain for several years, right leg pain, back pain much more than leg pain. You look and she looks like she has flat back, but actually I loaded her up on surgery map and measured her. She actually matches. PI minus LL is like 3 degrees. So I know you see a flat back, but it's not. I mean, her PI is really low, so she's fine. So again, she elected to, I don't want a fusion. Degenerative disease here with modic changes, 2 levels. This one is starting to go with a small node. Foraminal disc herniation on the right. She does have right leg pain, but predominantly back pain. So she went outside the US and we did a 2-level TDR. And she's 2 years now. And I haven't seen her lately, but she's 2 years now. So those are her X-rays. You're not always going to get great like side bending, but we found that clinically it doesn't correlate. Now, it's one thing if you do flexion extension and they're frozen, that's a different story. But on the side bending, there isn't a great correlation with poor outcome. And as we did the study, we paid special attention to when you go contralaterally and release the annulus, make sure you do a good job taking out all the bone fragments, ligamentous fragments, wash it out real good so that you won't get HO. I mean, that's what we did in the study. So our conclusion from that study was it's safe and reproducible. Neurologic complications were similar to the Charité IDE study, and there were no vascular injuries in this IDE subset. Now, remember, I can't show the whole IDE study because it was never approved, but I can show mine and Dr. Smith. And it showed good short-term and mid-term clinical results, and preserving the ALL with improved biomechanics may protect facet joints and adjacent segment disease. And you can maximize medial lateral end plate coverage with a large footprint prosthesis. And it is reproducible. I mean, you follow the technique correctly, it's reproducible. It's easy to revise, same approach. Of course, you cannot do L5S1. So what do I like to have? I think I'd love to see that revived, but maybe different materials, something viscoelastic. I talked to the M6 people. I said, you know what, take the M6 and just turn the keels, and you can do a lateral. I don't know. Yes, sir.
Can I ask you a question? PLL release in older patients where it's hard to get parallel distraction, do you do PLL release, or do you just rely on indirect stretching?
We do not do a PLR release, just rely on, basically you have sequential dilators, and you just dilate, get the trials in, and that's how you rely on that. So we did not do any PLR release.
So that's what is the hard part for when Mike and I do an anterior approach on somebody who's really stuck down, and we open up fish mouth, is spending a lot of time getting that posterior release so that it's nice and parallel. But maybe because you have good apophyseal ring coverage, you can do it by impacted distraction and not get subsidence or fractures and implants.
And that's been our experience. I mean, you got to rely on those apophyseal end plates on both sides. But again, we're not releasing the ALL, so probably that's why we're not fish mouthing either. Because you guys release the ALL and you go back, so it's going to fish mouth on you. I mean, we're not releasing the ALL. I mean, if you back the ALL, it's going to a fusion with this prosthetic design.
The other thing is, we always, first of all, I really enjoyed your presentation.
Thank you.
It was very forthright. We always spend time thinking that you have to cover the end plate so much. And on the coronal X-rays, it looks like you cover left to right perfectly. But on the sagittal images, it looks like it only covers about 2/3 of the end plate compared to when we do all the other disc replacements, the anterior posterior dimensions almost covered completely. Is that just limited by where you can get access because of the psoas, or where you're trying to put the implant, since the axis of rotation appears to be in the back, but some of them look like they were in the middle, and some of the implants to the back, but there's a lot of area of the end plate that doesn't get covered with this implant.
So the more anterior you go, the weaker the bone. That's one. Number two, the prosthesis comes in only 20 width from anterior to posterior. So we were bound by that.
Okay.
So we paid mostly attention to try and match that instantaneous axis of rotation. The ones you saw where you could not get posterior enough was limited by the plexus. Mm-hmm. Basically, you're getting nerve in the way. There was also a learning curve. So we learned as we did the cases, with the traditional way you teach, let's say, XLIF, you're at 90 degrees, right? So you go down, you follow your monitoring, et cetera, and you go. Then we learned as we went, maybe we should go in obliquely a little bit, so we're under the plexus. You go a bit halfway with the prosthesis, and then straighten out. So the ones you saw that are not that posterior, we were limited by the nerve, basically. We don't want to get a big neuropraxia or worse.
When you add up.
So that's the limitation.
When you add up the number of patients that had a little bit of weakness in their psoas and the quads and the dysesthesias, if they were all different patients, I don't know. That's almost a third of the patients. So is that fairly prominent that they all either going to have hamstring or psoas weakness, quad weakness, or dysesthesia?
The psoas and quadriceps most of the time go together because the psoas, we all tend to think, yeah, it's atony of the psoas. But remember, the psoas supply is also femoral nerve. The rectus femoris, not psoas, rectus femoris is a hip flexor, and that's femoral nerve. So how do we know some of that hip flexion weakness is not actually femoral nerve, partial neuroplaxia? So in our experience, it's been like if you have quadriceps weakness, you're going to have hip flexion weakness. So it's going to be your hip flexion weakness, hip flexion plus quadriceps, and usually the sensory goes together with them too. So I don't think it would be fair to add them all up, because there is overlap. But any kind of deficit, I would say, yeah, 15-20% if you combine everything. What was the Charité study? It was like 10% or less than that, the IDE study on neurologic complications. It was under 10%, I think.
It was less than 10%.
Yeah.
Okay, thank you.
All right, thank you
That was
very much.
very good.
All right.
Thank you, guys.